ఇదేంటి బషీర్ పెట్టింది కదా, మనం పెట్టిందా?
లేదు సార్, బషీరే కొంచెం లేట్ అయింది. బషీరే పెట్టాడు సార్.
అల్ట్రాసౌండ్ వర్క్షాప్ ఎవరు రిజిస్టర్ చేసుకున్నట్లేరు.
పెట్టున్నారు కదా సార్. 14th 15th ఏమో కదా సార్.
సాటర్డే సండే నెక్స్ట్ ఈ వీకే కదా, నెక్స్ట్ వీక్. అంటే మరి రిజిస్ట్రేషన్స్ ఉన్నాయో లేదో తెలియదు కానీ, బట్ అట్లీస్ట్ ఎవరు నాకు తెలిసి ఎవరు పెట్టినట్లేరు.
కిరణ్, గుడ్ మార్నింగ్.
గుడ్ మార్నింగ్ శ్రీకాంత్ సార్. గుడ్ మార్నింగ్ సార్.
గుడ్ మార్నింగ్.
Okay, we'll start, sir. The screen visible, Kiran?
Screen is visible.
Okay, so sir?
Yeah, no problem. Please go ahead, sir.
Okay, good morning everyone. So today we are discussing about multimodal post-operative analgesia or perioperative analgesia. It's a topic given in state conference, so kept the title as it is. So sorry. So basically, when I was given this topic, many people, like including KVD Praveen sir, asked what you are going to tell in 20 minutes. So multimodal analgesia is a very vast topic, and there are we can talk about each and every segment in this topic as a separate class. I mean, about opioids, about opioid-free anesthesia, about multimodal analgesia for various surgeries. There are articles for thoracic surgery, for gynecological surgery, for urological surgery. So it's highly and practically impossible to cover in any given specified period of time. So the aim of this talk is basically not to discuss in detail about each and everything, because most of the techniques and the drugs we will be knowing. So in that 20 minutes of talk, I just want to drive home the concept of using. So this concept is there, it is proven, it has evidence, but it's being practiced less. So which is why I choose to make this PPT of around 19 slides to drive the concept home. So we will just start with a small story. I think most of us, or at least 90% of us, are comfortable in Telugu. So ఈ స్టోరీ యాక్చువల్గా స్టేట్ కాన్ఫరెన్స్ లో చెప్తే టైం సరిపోదని చెప్పలేదు. సో మనం చిన్నప్పుడు అందరం చదువుకునే ఉంటాం, మన తాతయ్యలు నానమ్మలో చెప్పారు 3 చేపలు కదా. సో చెరువులో 3 చేపలు ఉంటాయి ఫ్రెండ్స్, సుమతి, కాలమతి, మందుమతి. సో చెరువు వేసవకాలం వస్తుంది, చెరువు ఎండిపోతూ ఉంటది, పెద్ద చెరువుకి వెళ్దాము లేదంటే జాలర్లు వచ్చి పట్టేసుకుంటారని చెప్తే ముగ్గురు, సుమతి చెప్తుంది, వినరు. సుమతి వెళ్ళిపోతుంది ఫస్ట్. వెళ్ళిపోయిన తర్వాత అలాగే నీళ్ళు ఎండిపోతాయి. సో జాలర్లు వచ్చి పట్టుకుంటారు కాలమతిని, మందమతిని. కాలమతి తెలివిగా ఆ టైంకి పట్టుకున్న టైంకి చచ్చిపోయినట్టుగా యాక్ట్ చేసి షీ విల్ స్కిప్ ఆఫ్. మందమతి మాత్రం దొరికేస్తుంది, హ్యాపీగా చేపల పులుసులోకి వెళ్ళిపోతుంది. సో దిస్ ఈస్ ద స్టోరీ విత్ అవర్ analgesia resonance also. Preemptive, you can compare with Sumati. Multimodal perioperative, what we are talking is Kalamati. And Mandamati ante మనం ముందు ప్రీవియస్ టెక్నిక్స్ కి ఫిక్స్ అయ్యి పేషెంట్ ని పెయిన్ లోకి నెట్టడం. సో దిస్ ఈస్ a short story to begin with. Now we'll go ahead with the topic.
Looks like it's the same like Who Moved My Cheese.
ఇది చిన్నప్పుడు చాలా ఫేమస్ స్టోరీ సార్ మాకు స్కూల్లోనే అట్లా. So basically the concept, how it all started. So it was introduced roughly 2 decades ago with recognition of pain as 5th vital sign by Joint Commission of Accredited Health Organization, so JCHO, and excessive, there has been, after the pain has been recognized as the 5th vital sign, so the focus shifted to management of perioperative pain. So then the beautiful wonder drug opioids are being used left and right. Initially, all the focus was on opioids as a monotherapy. So that led to opioid crisis. So at one point of time during the 1980s and 90s in the US, so it is the fourth most common used drug in the medicine after this antihypertensive lipidemic drugs. So the opioids are the fourth most commonly used drug at that period. So obviously it has led to all the side effects and also dependency, physical and psychological, all those things we know. So then this concept, actually two concepts arrived. One is completely opioid-free anesthesia and the second one is multimodal. So opioid-free anesthesia also covers majority of these multimodal what all we are using now. But there are few researchers and also so many articles are suggesting completely opioid-free anesthesia. Again, it's leading to inadequate analgesia. So this concept of multimodal analgesia incorporates opioids also along with the other techniques. So what happens when it is unrelieved acute pain? It leads to increased sympathetic activity, tachycardia, and hypertension. There will be increased oxygen demand. Perioperative, we get these cardiac events, and also there will be decreased regional blood flow, which can lead to infection and ischemia, which can lead to poor wound healing. And fear and anxiety of pain may cause sleeplessness and helplessness, which again leads to impaired rehabilitation. And splinting and shallow breathing due to pain, atelectasis, hypercarbia, and hypoxemia, which can lead to pneumonia. And also the most important thing, we see so many patients post-operatively with 7 years, 10 years duration of pain. Those acute pain, if not treated, so most of the times, even a small surgery like hernia, some patients have a chronic pain like more than some years. They present with 3 to 4 years. That when we track back, it's like some hernia surgery, and post surgery they will have that continuous pain. The acute pain not treated adequately can lead to chronic pain, which is very difficult to treat actually. So the idea behind is two concepts: two or more drugs, less dose of each drug, so that less adverse events. And another thing is two or more drugs, they act at different points in pain transmission, so that more efficient pain relief will be there. So the preparation, the first you have to understand the pain and then evaluate the pain using a simple, two most commonly used visual analog scale or numeric rating scale, where you ask the patient to scale their pain from 0 to 10, and it's a continuous dynamic process. Starting from pre-operative to intraoperative under regional and also post-operatively. So identifying the patients at risk for increased pain, like the patients with depression and also pre-existing some degree of pain, children, elderly. So you have to identify the at-risk population, and multidisciplinary communication and patient expectations mainly play very much role. You have to actively interact with the patient and tell him what it's going to like to be, and all these things play a very big role. So let's understand the pain first. So what happens when something just like maybe a needle prick goes into your skin? So the injured cells there release the leukotrienes and the potassium. Platelets will release the serotonin, and vascular injury results in the release of bradykinin from there. So these things, they will, all these leukotrienes, bradykinins, they will activate the nociceptors. So after the nociceptors are activated, they will release the neurotransmitters from there, which actually transmit the pain. So substance P, CGRP, excitatory amino acids like glutamate and aspartate, these will increase the signal. From there, the noxious stimuli is carried through A delta and C fibers. So from the C fibers to the dorsal horn, from the dorsal horn, they pass through the two tracks, spinothalamic and spinoreticular, and through the PAG and ARAS, ascending reticular activating system, they reach the various parts of cortex. So in the cortex, again, the area which is responsible for the pain generation and the area which controls is the same area which controls the emotion. So which is why when we are dull, depressing and lonely, we get to feel the pain more, and when we are happy, like in some functions or hanging out with our friends and all, so the pain will be less. So this is how actually the pain is perceived, and it's come down. Again, some drugs, they act at descending modulation inhibitory by facilitating the inhibitory amino acids, GABAergic drugs are there. So the descending modulation happens when the signal comes down from the brain. So this multimodal analgesia, it's like broad spectrum analysis, just like our broad spectrum antibiotics, where initially only gram positive used to be covered more. So then came the drugs that will cover gram negative, and later on the anaerobic. So like that, the spectrum of antibiotics, just like how it increased. So the exact term broad spectrum analysis actually applies very well to opioids, because it actually interferes at every point of pain transmission. Like you can see the list there, you can see opioids in the transduction, perception, and the brain, and also descending modulation, transmission everywhere. Transduction is just the signals getting pain signals are generating. Transmission is the pain signals carried to the brain along the tracks, and perception is the cortex thing, and descending modulation from signal down from the brain. You can see opioids everywhere. So which is why opioids are very efficient analgesics and widely used. But because of the side effect profile and also the dependence, then this concept of OFA and also multimodal emerged, where you can reduce the dose of opioids, or at least frequency of opioid administration, and you can use along with the other drugs and also techniques, regional techniques. So again, it's not like you fix these drugs, you give 1 gram paracetamol, 8 mg decadran, so some magnesium sulfate, 2 grams magnesium sulfate, and give a block like that. It's not like you give this set, you decide on this set, and you apply it to everybody. So you have to individualize therapy based on patient, type of pain, mechanism of pain, type of surgical procedure, location of the pain, and expected duration of the pain. All these things you have to take into consideration. So we all know these modes of multimodal analgesia, predominantly drugs, then comes the central neuraxial techniques, peripheral nerve blockade, and non-pharmacological measures. So drugs, again, opioids are the mainstay. They provide excellent pain relief, but in combination with other drugs, we can actually decrease the doses to a minimal, so where we can get efficient pain relief with minimal side effects. Acetaminophen, we are using commonly nowadays 1 gram paracetamol IV intraoperatively, which provides excellent pain relief and commonly used. But many researchers and studies, RCT, say the oral formulation is actually much suited to the perioperative analgesic regimen. So whenever the patient is free to take oral medication, you immediately switch from the IV paracetamol to the oral 1 gram medication. So comes and next comes the NSAIDs, the diclofenac, Dinapar AQ we're using commonly. Also COX-2 inhibitors have less side effects on gastro and renal. So COX-2 inhibitors like atopic, they can be used. So gabapentin and pregabalin, again, the less commonly used drugs, or at least we are not using them routinely. So they more of as preoperative tablet formation, starting from the preoperative period. So they, according to when I was like preparing for this topic, many consultants told that some of them used gabapentin routinely. So with a very minimal side effect profile, some patients complained of dizziness like that, but they saw excellent results with gabapentin. So then comes the dexamethasone. In addition to preventing PONV, postoperative nausea, vomiting, dexamethasone also helps to decrease the pain. So alpha 2 agonists, which are the again our famous drugs, clonidine and dexmedetomidine. So dexmedetomidine is being more favorable drug now. We are using as continuous infusion in the perioperative period, and personally I have seen very good results with dexmedetomidine intraoperatively when given. We have seen some beautiful recoveries and with very minimal pain. So ketamine, once a very favorite drug for all of us, so gradually has fallen out of favor due to side effects and all. But in analgesic dose, generally hallucinations and all, they're kept to minimal. So again, lignocaine IV infusion can be given intraoperatively, preceded by a small loading dose. And magnesium sulfate, again, this magnesium sulfate, again, there are some studies which quote that it still needs some large scale studies to know exactly how much amount of magnesium sulfate to be given and titrated to the type of surgery and all. Duloxetine is also it's an SNRI. It's used as antidepressant, but again, the role has to be established. They're using in some centers. So when you give drugs again through various modes and like IV, IM, oral, but also when you're giving IV, it can be our nurse or doctor control, like you decide a fixed dose, or it can be patient controlled analgesia. So central neuraxial techniques, again, epidural, our very favorite post-operative analgesia. It's like provides excellent analgesia and completely pain-free patient in most of the cases, at least, unless we get a patchy blockade in some cases. So again, the same problems when it comes to the flip side, when we're talking like sometimes we are cut down by surgeons for the cost, and also the technical related complications. Sometimes we may not be able to place the epidural, but it offers excellent analgesia. So intrathecal, we can give short doses of morphine or fentanyl, which can provide good analgesia up to 12 to 14 hours. So facial plane blocks are now the techniques of choice for perioperative analgesia. We are using erector spinal blocks, tab blocks, fuel blocks, transverse abdominal plane blocks, and quadratus lumborum blocks, and also we can give a serratus anterior plane block. All these blocks are very simple. I mean, like even if you don't have an ultrasound or CM for imaging, also you can give landmark guided very good. SAP is just you palpate the fifth rib in the mid-axillary line, hit that, and just come back a few and you give the drug. Serratus anterior plane block works very well for chest surgeries. And also erector spine is same. You hit the transverse process, come out a few and give the drug, 20 ml of ropivacaine or like diluted bupivacaine. And TAP, you all know, we have been practicing the transverse abdominal and regional blocks for upper extremity surgery. Even when you're doing under general anesthesia for some indications and all. So again, the regional block can provide good postoperative analgesia. Plexus and individual nerve blocks, we have seen very good results with the simple femoral nerve block in trauma cases, even in ICU, where it provides excellent analgesia for the first initial 12 to 12 hours at least we have seen. So the trauma patients are more favorable for splinting and all. So previously used to have excruciating pain, and that they just do it without any, or just by giving some 25 mg fentanyl we used to do before. But femoral nerve block works well even in ICUs for the trauma cases. So wound infiltration for with local anesthetic, and also the lab port infiltration, all these things they add up and provide better analgesia. So whatever you do, this concept, entire concept, basically the thing like just in the story, when the pain hits you, you add then. So in the operative period, you give multiple drugs so that these will mitigate the pain when it is generated, so that there will be very minimal requirement post-operatively. Most of the times we can happily switch over to tablets instead of using IV analgesia when we give proper intraoperative analgesia. So non-pharmacological, again, these are less practiced, more of practice in chronic pain. But there are so many studies which say the acute pain, when we bring them to the acute pain territory also, we can get very good results. So transcutaneous electrical nerve stimulation, acupuncture, music therapy. So these are all very, I mean, like TENS, we have this acupuncture is a bit difficult to regularly practice, but music therapy can be happily practiced. So guided imagery, where the patient is asked to imagine some feel-good moments of, or we can show him some happy images of his family or well-spent times like that. So to distract away from the pain, virtual reality is a one step ahead in the guided imagery. We are using VR in all fields now. So the cold compressed muscle, physical activity coaching, graded exercise therapy, behavioral health interventions, all these play a significant role even in acute pain to mitigate the pain and preventing it to turn into chronic pain. So coming to some guidelines, these are ASA guidelines for perioperative analgesia. So the recommendations relevant to multimodal analgesia, the extreme right one. is the when possible, implement multimodal pain management therapy in treatment across patient populations and procedures. Unless contraindicated, deliver a continuous regimen of NSAIDs, selective COX-2 inhibitors, and acetaminophen to the patients in acute pain. So consider regional blockade to deliver multimodal local anesthetics in managing pain. At all times, optimize dosing efficacy while minimizing the risk of adverse effects. So individualized medication, dose, route, and duration of pain management, which is very important. And also you have to regularly converse with the patient, or at least like 4th to 6th hourly, you can make rounds and ask him how he is feeling. And thereby, just like how we titrate the epidural infusion, when we keep them, you ask the patient pain, you just increase from 5 to 7 ml or decrease that from 5 to 3 ml, like that. So you have to regularly talk to the patient post-operatively and manage the medication. So Australia and New Zealand guidelines, so compared with mainly opioid-based analgesia, multimodal analgesia improves pain while reducing opioid consumption. Burn injuries require aggressive multimodal analgesia and multidisciplinary treatment. The patient's multifaceted pain experience requires individual management using diverse analysis and route of administration that all require evaluation and consideration of risks. So this WHO analgesic ladder, so coming to the basic tenets, oral administration of analgesics is preferred whenever possible. So analgesics should be given at regular intervals. The analgesics should be prescribed according to the pain intensity as evaluated by a scale of intensity of pain. Dosing of pain medication should be adapted to the individual. Analgesics should be prescribed with a constant concern for detail. So why this concept, which looks so good on paper, is not being practiced widely? So even in the Facebook group where we used to connect, it's a global group is there, the anesthetist there, whenever some UK practitioners and some others talk of, even some people in North are aggressively practicing this. So when they say, speak about multimodal analysis, this is a common comment like, why this khichdi anesthesia, you are mixing so many drugs, and so it will not work, it will have more adverse effects, like that. And this is the same thing. So that comment arised of this one, unfamiliarity of usage of certain drugs in the perioperative period. So some all these drugs like dexamethasone or magnesium sulfate or gabapentinoids, we are not commonly used to use these drugs for the perioperative analgesia. So that is the mental block we are having regarding certain drugs. And the cost, again, this it can differ. Like in your hospital, you may be having the freedom of using whatever you like, but some hospitals are at least 60 to 60, around 2/3 of hospitals in our, at least in our country, we are still under scrutiny, like anesthesia. These people are still using so many drugs, so much cost is going on. And every case, at least in 1 in 3 cases, we again talk like, just like before the class, me and Arvind were again discussing about placing an epidural for a very complicated patient. Again, that case is posted under EHS. So like this, all these constraints come to practical applicants again. But once you convince the team that it's actually cost effective and we can actually implement and see the results in some patients, they will only agree later on. And this physics concept, what we learn in our school days, so inertia of rest. So we are comfortable using the current regimen. So some sort of pain or degree of pain patient will have, it is anticipated the type of surgery and nature of surgery. So it's okay to have some degree of pain to the patient. So we are like pretty much comfortable with this concept and doing these sort of things routinely. So once we step out of the zone and aim for a near complete pain relief, then we can actually manage the patients better. So, and we can see the results too. So a few studies, this is published in Anesthesiology in 2020 article in the US. So about the perioperative gabapentinoids, which we are talking before. So this has been extensively studied over. It's an editorial article based on the study of the previous 20 years. So they say there is gradual decline in the evidence of benefit for gabapentinoids and increase in the evidence of risk. This especially, I discussed with few of the consultants. There's those who have been using gabapentinoids, but they say that dizziness and some GI disturbance is there, but not so harmful, and we have seen some good results. But this is the evidence where the benefit is decreasing and the evidence of risk is increasing for gabapentinoids. And according to this major editorial article, they are not recommending the usage of gabapentinoids in the perioperative period. So this again a sort of this Elsevier publications. This article was published. So this actually sums up our talk. So the alpha-2 agonists have been shown to have opioid-sparing effects, but can cause hypotension, bradycardia, which we commonly see with these drugs, and also they're more with clonidine than dexmet. So we have switched over to the dexmedetomidine and placed clonidine for most cases, and must be taken into consideration when administered. Acetaminophen is commonly used in a multimodal approach, with recent evidence lacking for the use of IV over oral formulation. Patients able to take medications by mouth. So whenever the patient is ready to take medication by mouth, you switch to oral formulation of paracetamol. So studies involving gabapentinoids have been mixed, with some showing benefit. However, future large RCTs are needed. Ketamine is known to have powerful analgesic effects, and when combined with magnesium and other agents may have a synergistic effect. Dexamethasone reduces postoperative nausea and vomiting and has been administered to be an effective adjunct in multimodal analgesia. The SNRI drug duloxetine is a novel agent, but studies are limited and further evidence is needed. Overall, a multimodal analgesic approach should be used when treating postoperative pain, as it can potentially reduce side effects and provide the benefit of treating pain through different cellular pathways. It is the main concept. So it adds at different levels so that we'll have a sort of all bases covered in the perioperative analysis regimen. Thank you.
Thank you, Srikanth. I think moderator has to come now. Then I'll take with the permission of moderator. Where is Omkar? Moderator లేకుండా స్టార్ట్ చేశారు తప్పు కదా
ఉన్నాడు సార్ ఉన్నాడు చూడలేదు నేను
ఏంటి moderator
BMCలో బిజీగా ఉన్నాడు
సరే ఏం లేదు what I wanted to really ask is whenever we have a sedation, we have a scale, whenever there is an objective method of doing it. For the pain, do we have an objective method of assessing? Because if it is anesthesia, depth of anesthesia can be monitored by a bispectral index, or if you see the EKG or neural monitoring to understand up to certain level, even though we don't monitor regularly. What I want to understand is that because there is, as you said, Kichdi, or whether I want to become a Mandamandi to Kalamati. So how you want to really go with the objective method, not as a subjective method of assessing the pain?
So this is actually, I say, a beauty or a flip side, sir, but to be taken both how we apply. Pain has really got no like quantitative assessment like how we do in with temperature or pulse rate like that. It's always subjective, sir, no matter how it's whether it can be acute pain or chronic pain. The patient says he's in pain, he's in pain. He may not like you also, then also you can say you didn't decrease my pain. So but that's the point of but in perioperative period we can we have some few index like increased heart rate going up. Again, that can be due to many other reasons, but pain can be definitely one of the reasons for that increased sympathetic activity, which we can see in the monitor in the perioperative period. But if you ask me, definitely there is no objective measurement, sir. But only this, when we are going for surgery, we can see the increased heart rate and pressures. If we rule out the other causes, then it can be pain, and we can supplement with one of them. The main change, what we noticed is one thing I told that about Dexmed with usage of dexmedetomidine, we have seen definitely smoother recoveries there, even for complicated surgeries and a completely pain-free patient awaking. So, and also the post-operative analgesic requirements have come down significantly. So commonly what we are giving is we are like using some block in addition to IV paracetamol and dexmedetomidine.
Now everybody is
And
talking about
fentanyl.
fentanyl. Yeah, opioid and dexmedetomidine. Dexmedetomidine is which classification drug it is?
Alpha two agonist.
Yeah, alpha two agonist and opioid.
Transmission, so transmission of pain, mainly it acts on transmission of pain, so alpha two agonist.
So you mean to say that the combination of dexmedetomidine, paracetamol,
Paracetamol acts at
and
this transduction level, signal level.
and fentanyl.
Opioid it acts everywhere. So fentanyl we are giving just at the start of the surgery, and sometimes if it is a major one in middle, again after 1 hour or 1.5 hours, we are supplementing with 101 mg. Because initially, again with 200, sometimes we have seen even with 200 mg chest rigidity, we have seen in RK, sir. RK lo Shyam sir and Shyam sir ఉన్నప్పుడు just with 200 mics we faced much difficulty in ventilating the patient. As well as some bad case వస్తే ICU ko shift చేయలేదు, అక్కడే ఇంటిబేట్ చేసేద్దాం శ్యామ్ సార్ అంటే లైక్ జస్ట్ 200 mics ఫెండిల్ ఇచ్చాము. జస్ట్ వెంటిలేషన్ చాలా డిఫికల్ట్ అయిపోయింది. అప్పటి నుంచి ఐ వాజ్ లైక్ 200 ఇవ్వడానికి కూడా భయపడతాను నేను ఒకేసారి.
Chest discomfort, chest tightness.
Chest tightness, sir. Ventilation. Actually, they say that comes with more than 300 like that. So, like 6 mg per kg can take one. Like with 200 also, I've seen them. So, maybe one-off case, but case since I was like splitting the drug whenever I'm giving like 2 times or 3 times. Kiran, explain.
అదే కిరణ్ జిఎంఎల్ బాగా చేస్తున్నాడు. జిఎంఎల్ కిరణ్ గారు నువ్వు చెప్పేది
the volume of cases that regularly.
హరి ఉన్నట్టు. నో హరికృష్ణ ఉన్నట్టున్నాడు. హరికృష్ణ చైతన్య ఉంది కదా,
చైతన్య అరవింద్.
ఐ వాంట్ టు నో డిఫరెంట్ సెటప్. చైతన్య పత్తులో ఉంది కదా.
చైతన్య ఇస్ దేర్ సార్.
లేదా
Sir, good morning, sir.
Harikrishna. Are we giving all these three, or are we doing this? How are we giving management? Particularly, how we are giving in Oasis, how we are giving in care, and how we are giving in somewhere. Like how we are giving.
Sir, we always follow multimodal analgesia, sir. Wherever possible, we try to give epidural or we try to give blocks. And yes, as sir mentioned, multimodal analgesia is what we follow. We try to, we don't depend on only one drug. We don't depend on only an opioid or something. We try to use different drugs and different modalities so that the patient is pain-free in the perioperative period.
Like, do we look into the cost effectiveness of, as he was telling, EHS, RGC, and those kind of cases? That's tough, no, for the cost, because dexmedetomidine is costly and they give the packages. How we really manage that? Which way?
Yeah, yes, sir. If we think that the patient needs it, then and there is no other alternative to epidural, then we might ask the surgeon for epidural. Otherwise, if there is any, if it is an abdominal surgery, then we try to give the tab block, sir. So we try to manage it through blocks, or we have fentanyl or buprenorphine patches. So at least that we'll be keeping, sir.
No. People like you who have intervention knows they'll do, but the people like us,
Sir?
only drug. People like you can go for tab block or in nerve block, but people like us cannot go for. We have to go only IV medication. Correct, అంటే కాస్ట్
అంటే మనకి I think patches అంత కాస్ట్ కాదనుకుంటా సార్. ఫెంటనిల్ ప్యాచ్ అండ్ బుప్రనాఫిన్ ప్యాచ్, they are not that costly.
Basically patches are not actually
Fentanyl patch is 750. So fentanyl patch is 750 as I know.
550 for the 25 mics patch, sir. But transdermal patches are actually మా దగ్గర ఉన్నది అయితే 550 సార్ 25 మైక్స్ ప్యాచ్. సో బుప్రినార్ఫిన్ కూడా మనం వేసే 5 మైక్స్ 5 mg ప్యాచ్ 450 రూపీస్. బట్
That's what I'm telling it.
acute pain లో transdermal patches are actually not indicated, sir.
I just want to Kiran and Omkar, Chaitanya and Harikrishna Mullapalli. Just wanted to understand how really we assess a pain when the patient is in anesthesia. Because when the patient is there in routinely, we know that patient is having a problem.
I
He will
think
tell you the pain.
vitals are indicative, sir.
Vitals. You look at the vitals, Srikanth, because you look at hypertension, you look at everything, you look at vitals for the pain. Normally, the top process of every anesthesiologist goes into the pain is because of vital changes. You have to think about pain management.
It's when he's under GA, I was telling no, sir, that's the only signs we get like tachycardia and hypertension. But again, it can be due to lighter pain, so or a strong surgical stimulus at that point. So all these things we had to
We
take.
don't know whether
Sir?
it's difficult to differentiate between the depth of anesthesia and pain causing distress.
We treat in a step by step. We increase the depth of anesthesia and still they are high, then that is what I follow, sir. So increase the depth of anesthesia, still the heart rate and others are shooting up, then pain can be the reason.
Sir, IV
Thank
analgesics,
you.
we have paracetamol, tramadol, ketorolac. I think we have all these.
So try using magnesium sulfate actually works very good, sir. And also dexamethasone. Dexamethasone we have a dual advantage of decreasing PONV and also in pain. But again, like steroid diabetics we cannot use. So that's the problem. So but magnesium sulfate works well, sir. It has got
Magnesium sulfate, how you give?
2 grams, sir. 2 grams for perioperative period in 100 ml or 20 grams.
Sir, good morning,
Chaitanya,
sir.
do you give magnesium sulfate?
Sir?
Chaitanya, do you give magnesium sulfate?
Sir, we haven't tried it, sir. We have never given it. So I think now we'll try that. That theoretical, but we have never tried. Then Srikanth sir, maybe he has already has experience with it, so we'll try it.
Omkar, Chapati.
Sir, good morning, sir. Sir, what about combining intramuscular and intravenous during this thing, sir, like surgery or post-operative period? We give some sort of diclo-IM and go for tramadol trip. Means I did not follow the topic. Are we talking only about giving IV and transdermal, or are we talking about IM also, sir?
Any route of drug, but transdermal actually, I keep on saying this to Arvind also, transdermal patches are not actually, they are evidence-based for acute post-operative management.
I'll prefer for acute pain, but in our regular practice, going much of fentanyl patches.
Previously, our gynecologist used to be very much in favor of Dr. Sunita, but I strongly disgraced her.
So
I think even for transdermal patches to work, even for transdermal patches to work, I mean, it has to start along with the IV. I mean,
yeah, they will take 7 to 8 hours, but that's not the problem. Sir?
Gynecologist ఏం వాడేవాళ్ళు?
సునీత మేడం సార్ మా గుండెర్గా ముందు ఆవిడ బాగా ఫేవర్ అనమాట. ప్యాచ్ పెట్టామని సార్ అందుకే చికెన్. సో బట్ TD అంటే ట్రాన్స్డర్మల్ ప్యాచెస్ తో ద ప్రాబ్లమ్ ఈజ్ febrile spikes. So fever episodes again the absorption will be more. So which is why there is negative evidence for usage for transdermal patches in the perioperative period, because most of the times 90% of the times we'll be managing them in rooms, not in ICUs. So again, monitoring is difficult. We actually before like some 3-4 years back, we have seen 1 or 2 cases of respiratory depression with transdermal patches in room. So we have stopped using them for acute pain. There is no evidence. Magnesium sulfate is just like ketamine only, sir, NMDA receptor and same the mechanism of action.
Sir, Omkar sir, why intramuscular? Sir, do you use any intramuscular drugs?
ఒకసారి అరవింద్ సార్ ఏమడుతున్నారు?
అరవింద్ అయిపోనివ్వండి.
Sir, Omkar sir, why intramuscular, sir? Do you use any intramuscular drugs intraoperatively?
మోడరేటర్ నిన్ను క్వశ్చన్ అడగాలి, నువ్వు మోడరేటర్ అడగకూడదు.
No, for post-operative time also, normally what we do times is for end of the surgery, if the patient is too apprehensive and all, we can give, I personally do this, I give diclo IM, and after that extubation or else post-surgery, tramadol drip or something, we run like this.
Tramadol,
the same thing, the same diclofenac can also be given IV also, no sir? And I mean, why
specifically for long time than IV, right? And action duration also, there will be a difference of around 4 to 6 hours difference in period of action when we are giving IM and IV.
Okay, this I didn't know, sir.
Our main intention is to reduce the number of diclo injections. And sir, one more thing, the main challenge of giving multimodal anesthesia, especially if you're dealing with the CKD or liver case, means I think that window will be very narrow. And in that cases, obviously you have to go for regional blocks, which will help a lot. Any comments, sir?
Regional blocks are the mainstay, Omkar, for any multimodal regimen. Regional blocks are the mainstay. Also, this entire concept actually, which is why I told the story at the beginning. So all these studies and these RCTs are indicating you use this multimodal concept not in the post-operative, but during the surgery. During the surgery, when the actual tissue trauma occurs, you block that. So then post-operative, you can happily, you will be astonished when you hear the stories. So when they say the people who are practicing, so they give all these magnesium sulfate or dexamethasone, it will be again titrated based on the patient. So they are giving all these drugs intraoperatively only. So post-operatively, they're happily coming down immediately to oral medication. That's what the evidence of the oral paracetamol. That for surgeries, for unless for very major surgery or involving more tissue trauma, for majority of surgeries, they're immediately switching over to the oral medication in the post-operative period. So the facial plane blocks or the regional techniques play a very major role in the multimodal analgesia. But tramadol ఎందుకో నాకు కొంచెం uncomfortable using tramadol. Commonly used, but డెఫినెట్ గా పెయిన్ రిలీఫ్ వచ్చిన, అది జోక్ ఉండేది యాక్చువల్ గా, పెయిన్ రిలీఫ్ వచ్చినా రాకపోయినా వామిటింగ్ డెఫినెట్ గా వస్తుంది ట్రెమడాల్ తోనే. సో ఇట్స్ ఎ గుడ్ డ్రగ్, బట్ పర్సనల్లీ ఐఎమ్ నాట్ కంఫర్టబుల్ యూజింగ్ ట్రెమడాల్.
Sir, in cost effectiveness, especially Analgesia cases and all, we are left with only diclo. At max, if surgeon is having kind heart, tramadol.
No, that's what I'm saying. Try these magnesium sulfate and dexamethasone. Those are also cheap drugs only.
Sir, 3 ampules paracetamol, sir.
3 ampules paracetamol. All these things you can go in a cost-effective, surgeon-friendly.
Even I also started practicing the 3 ample paracetamol handle awareness.
You know, ABC kochunta 5-6 ఏళ్ళ క్రితమే practice చేవాడు. 3 ampules is our gold standard for Analgesia cases.
Sir, any new methods which any hospital or anywhere they are practicing regarding post-op analgesia? Anything new?
నువ్వే చెప్పాలి.
నేనే చూడలే. The leading
It's like
freelancer.
when we talk about new, this is the new, like facial plane blocks are the new thing. Definitely. I mean, like it's been practicing since 5 years, but 5 years is a relatively new period in anesthesia, at least in our parts. So since the last 5 years, I have seen more and more uses of try this serratus anterior plane block onca. That is very easy procedure to do in the chest surgeries. So just you palpate the fifth rib, అది ఈజీగా నిపుల్ నుంచి డౌన్ వచ్చేది fourth and fifth years. So కింద fifth rib చూసి mid axillary line లో you just hit the rib. Most of the times it will be superficial only, and you just come out a few and give 20 ml 0.2% propane or diluted bupropion 0.15 bupropion. Works well. Facial plane. Anything else?
Sir, how about buprenorphine patch, sir? Any comments on this? Means
No,
experience using
no usage of transdermal patches for acute pain. Strong.
Sir, normally in long-acting cases, I mean, for chronic pains
Sir,
also.
it acts well, sir. Buprenorphine patch acts well.
Acts well, but a stick no.
Maybe not for acute pain, but yeah, buprenorphine patch we have tried.
Acute pain, the only thing is if you're keeping the patient in ICU, it's fine because you're monitoring. Again, with problem with it works well with fentanyl because fentanyl has only 3 days of duration, but buprenorphine you have action for 7 days. Again, you can't keep the patient for 7 days in ICU for at least 90% of cases, even for major cases. So that's the problem. So febrile spikes, you're gone, or else you ask the nurse to inform you, which is very highly impractical. Whenever the fever comes, you can't go run from your home, whatever you are doing, or you can see like that, at least in most of us. That is why they are not recommending transdermal patches for acute postoperative pain. So it takes on an average 7 to 8 hours for fentanyl patch to work and 5 to 6 hours for buprenorphine patch to work. Acute pain 20 for chronic pain buprenorphine. But again, Praveen sir was telling he is again not using them for cancer pain because buprenorphine has got a sealing effect. So cancer pains lo excruciating pain untadi kabatti at some point they stop working. So the drugs with sealing effect should not be given in cancer pain according to him. So chronic non-cancer pain, you can try buprenorphine patches. But again, acute pain, they work well, but there is evidence against it if something goes wrong, just like all our anesthesia complications. 100 or 200 or 1000 a patient వస్తుంది వచ్చినప్పుడు it will be అది problem. So the incidence is less, but it cannot be ruled out, and there is no evidence to support your uses. So that's the main problem. ఆడొచ్చి అద్దలు బదులు పడేస్తే పర్లేదు, కోర్టుకి వెళ్తే మాత్రం you cannot stand.
Sir, any new patch or any new drug is there? So like fentanyl patch, buprenorphine,
Diclofenac, ketorolac patch, diclofenac patches. These you can use perioperatively. These are the approved. If you are willing to use, but diclo patches, the feedback I received is not so much effective when compared to the IV formulation or even slightly better than oral, but again shorter duration. Diclofenac patch acts for 24 hours. So that actually you can try for the perioperative. Cheap also, I think, compared to obviously it will be cheap compared to opioids. Anything else, Omkar, or we'll wind up? Okay. Chala. Okay. Answer on that. Okay. Thank you, everyone. We shall meet next week. Next week, Babu Omkar, made class.
Sound ఉండదు ఇంకా.
ఇంకా అంతే సార్, కేసు వచ్చింది చూసుకోలే, లాస్ట్ లో ఏంటి సార్ మాట్లాడుకున్నారా తర్వాత అడుగుతాడు ఫోన్ చేసి. లాస్ట్ లో ఏదో మాడుకున్నారు ఏంటి సార్ అంటాడు తర్వాత అరగంట తర్వాత ఫోన్ చేసి. ఓకే రైట్ దెన్, చలో బై.
థ్యాంక్ యూ.